Wilson's disease is an inherited disorder of copper metabolism. Let's walk through it. History and discovery. It begins with Samuel Alexander Kinnear Wilson's clinical description in 1912. The copper overload connection was established in 1948, and the causative ATP7B gene was identified in 1993. Treatment milestones came in waves: British anti-Lewisite injections, then D-penicillamine in 1956, zinc salts for reducing absorption in the 1960s, the first liver transplants and triethylene tetramine, trientine, approval in the 1970s. Pathogenesis. The disease follows autosomal recessive inheritance. Mutations in the ATP7B gene, which encodes a copper transporting ATPase, impair biliary copper excretion. Copper therefore accumulates systemically and in the central nervous system. Clinical phenotypes. This is where the disease shows its many faces. The hepatic presentation typically has onset before 30 and includes jaundice, hepatomegaly, edema, ascites, and chronic cirrhosis. The neurologic presentation reflects basal ganglia involvement, dysarthria or speech difficulty, dystonia and rigidity, and the classic wing-beating tremor. The psychiatric presentation can include personality changes such as irritability and anger, depression and anxiety, and declining school performance. Ocular manifestations are hallmark signs: the Kayser-Fleischer ring in the cornea and sunflower cataracts in the lens. Other clinical features include hemolytic anemia, renal tubular Fanconi syndrome, skeletal effects like osteoporosis and rickets, and delayed puberty or amenorrhea. Diagnosis. Diagnosis is guided by the Leipzig scoring system based on expert consensus. Biochemical findings include low serum ceruloplasmin, increased urinary copper above 100 micrograms in 24 hours, elevated hepatic copper over 200 micrograms per gram dry weight, the penicillamine challenge test, and radio-labeled copper-64 incorporation studies. Molecular findings confirm ATP7B loss of function variants, common ones being H1069Q, M645R, and R778L, detectable through whole genome sequencing. Medical treatment. Management targets copper in three ways. Copper chelation uses D-penicillamine given with vitamin B6, trientine, which has fewer side effects, and fast-acting tetrathiomolybdate. Reduction of absorption relies on zinc acetate, galzine, which induces intestinal metallothionein and serves as maintenance therapy. Advanced management for severe disease includes liver transplantation and emerging options like methanobactin, a bacterial peptide, and viral gene therapy using AAV8-ATP7B. Finally, special considerations. In pregnancy, chelation or zinc should be continued, but breastfeeding is avoided.